I need to get to you.
My success story for today is going to be dental implant success. And of course, we all define that differently. I guess everyone in the room knows Craig, who's sitting in the front row right up here, right? Our Noville guy.
Hey.
Craig defines implant success by the volume that he sells, right? Right, Craig, that's your only definition for success. Dr. Vieira defines success based on the number that he places on a daily basis. And of course, for me, the most important thing is your success, right? You know how that works. And so dental implant success is a funny thing. It's historically been defined purely on the implant fixture itself, without any regard for soft tissue, without any regard for patient satisfaction, and without any regard for ability to place a restoration on that implant that a patient can maintain, that you can do without some great degree of complexity and cost. And so implant success has always been very surgically oriented and completely forgetting the concept that the implant's only purpose in being is for you guys to place a restoration that is attractive, functional, and cleansable, right? That's the only purpose for it being there. And so dental implant success has historically been defined, and so when Charlie started going to work out at 4 in the morning, implant success was mobility of less than 1 millimeter in any direction. Mobility, right? That's the definition, the NIH definition. It's okay to have radiolucencies. And by the way, if you read the old Brandemark studies, the reason they were all bite wing radiographs is because all the implants had apical lucencies. They all did. Not all.
Yeah, a lot.
Okay.
Yeah.
Bone loss no greater than 1/3 of the vertical height of the implant. Are you all feeling good about
Yeah,
that?
I see relief.
Yeah. Inflammation that you can treat with absence of paresthesia and no violation of the nasal passage, which is always an important thing. And it's got to last 5 years, 75% of the time. That was the NIH definition for implant success. Now remember, when implants first were designed as we know them today, Brandemark, you know the story about Brandemark and the little titanium boxes that went into the rabbit tibia, and they studied, he studied bone growth angiogenesis, and he couldn't take the titanium out because it stuck to the bone. And most folks would have said, crap, I can't use titanium, and thrown it away and found something different. He realized it was something that would be useful, and invented osseointegration as you know it today. But you know, back then, the entire focus was on macro geometry. You know, the external hex is only there so you can place the implant on the original implants, right? That's the only reason the external hex was there, to place the implant, because implants were all designed for full arch cases. And so a flat top was adequate for a multiple splinted restoration. The external hex was only there to actually physically place the implant.
Did not know that.
Yeah. And so it was macro geometry, but primarily material. And of course, titanium was the material of choice, even though stainless steel was tried and sapphire was tried and vitreous carbon was tried and all kinds of things were tried. But this is the success in 79 by definition. In 86, it got better. We could now achieve immobility. I'll tell you, my old boss at Cleveland Clinic went to the to Linkow's clinic in New York City as a class trip, and he said every implant that he looked at in that patient in that clinic had pus oozing out of it. Every single one. Every single one had pus oozing out of it. Way back. So no apical lucencies, less than 0.2 millimeters of bone loss, and a success rate of 85%, 5 years, 80% at 10 years. So we're doing better. 80% doesn't sound so great, but it's better. It's better. But it's all a focus on the actual material, in this case titanium, which is a metal, but obviously titanium oxide, which is the surface of titanium, is a more ceramic than it is a metal, just like zirconia is a metal,
Right.
which is an oxide to make you zirconium, but they're both metals, okay? So we focus on the metal, but then something changed around 2000 or so. And if you can't read this in the back, what changed was this is short-term implant success. In the maxillary arch, failure rates routinely exceeded 20%. In the mandibular arch, it wasn't uncommon to get above 5 to 10% routinely. But something changed in 2000, and it led to a reduction in focus on the material and a realization that the surface mattered as much or more than the material, because this is when Ti-Unite implants were released. And Ti-Unite, as you know, is a surface coating, which is an anodized surface, anodization process, which is an electrochemical process, which is an additive process where you create porosity, that's not the right word, a roughened surface on the implant. And so now suddenly implant success rates went way up, 80% less for failures, early failures with Ti-Unite in the maxilla, and 50% less in the mandible in around 2000. So it's not just the material, but at this time, it was the roughness of the surface, okay? It's gonna change, but at this time, it was purely a function of roughness, okay? And when All-on-4 was popular, Mish used to drive me crazy. I shouldn't talk about people who have passed, but I'm going to anyway, because he would cite these numbers with machined implants and say All-on-4 didn't work, you know, a quarter of the time, but we weren't using these implants and these were old data, right? So he was citing stuff that was completely out of context and completely untrue because it was completely out of context. And so we realized that Ti-Unite, same material, but a change in the surface from that old machined implant had a huge impact on success, huge impact. And so what do you want in an implant with your rough surface? So SA is simply an arithmetic expression of averaging the heights of the peaks with the lows of the valleys. Okay, that's all it is. It's just a measure of roughness. The higher the number, the greater the difference in the peaks and the valleys, okay? So this is not very rough, it's slightly rough. Less than 0.5 is certainly less rough. 6, 7 is more rough. You've got a complex surface with an energy to it, which is now beginning to be understood. And what happens with that roughened surface is these things that you know, that healing proteins from the body can form, a blood clot can form, you can get blood vessels forming, get newly forming bone on the implant, you get progenitor osteogenic cells all migrating. So the implant surface is truly promotive of osteogenesis in the body. It's got to be in the body because it's got to have nutrition from the body, calcium from the body to grow bone, but it is a biologically active surface. And so again, when you have this, you get improved implant performance, you get higher success, lower failure, improved long-term success, stronger and faster bone healing with these new surfaces. And so then the focus went on how can you impact the surface. And so everybody wanted to get a stronger implant in bone, a longer term success, shorter term success. And so they all went to improved roughness. But as it turns out, there are two ways to do this. One is to subtract, which means sandblast and/or acid etch. The other is to anodize or plasma spray. As it turns out, of all the techniques available, the Ti-Unite surface, the anodization, is the most successful when you compare them all. But it's still in the context of surface roughness without a true understanding of surface energy and surface chemistry. And so the problem is, as I understood it 10 years ago, and I had this conversation with patients very frequently, was my problem is I need your bone to attach. So the rougher the implant, the better the bone attachment, right? The problem is if you get infection around that implant, that surface roughness kills me because all it is a bunch of little bacteria condos, and I can't get rid of it. If you got true surface roughness, I can't clean it out very well. So we got two problems, right? Or we potentially have two problems that are mutually exclusive. And so we've got to have cleanability, but we've got to have tissue integration. And there's a reason you don't see these anymore, right? I had a guy ask me one time years ago, do you do those? And I take a lot of them out. I don't do them. I take a lot of them out. And there was a reason for that, is because that ain't cleanable. You get something in there, you're screwed. You're completely screwed. And so what you have to do is create a surface that is osteoconductive, but not create condos for bacteria. Right? And so there wasn't a good understanding of that because we've gone through the material stage. You know, we're going to use titanium or zirconia. We've gone through this surface roughness stage, but now we've got this contradictory problem that we don't know how to overcome. Well, as it turns out, as we begin, I keep saying we, but I mean Nobel Biocare, of course, because it's their name on the slides. And I did take a lot of their propaganda crap out of this, just so you know. But I tried to leave relatively objective science, because if I put their propaganda in with their opinion, then I don't have time to share my opinion, which is really the most important.
That's more important.
That's it. Or cow pictures too. Cow pictures.
Right.
And so, so as it turns out, the subtractive technology, which basically means shooting this thing with sand, right? Sandblasting, doesn't change the chemistry of the surface. It's still a plain titanium, right? You can acid etch it, but don't let them fool you. Acid etching originally started because the material they were blasting the surface with became embedded in the titanium, and it was stuck and it screwed up integration. So they had to acid treatment to get rid of all the stuff they used to blast the implant with, okay? And so, so now you've got a subtractive technology, which doesn't change the chemistry, but it does certainly, depending on how hard you blast it and what particle size, and then the acid etch has an impact as well. It does not change the chemistry of the surface compared to the process, which is an electrochemical process, anodization, where you add, and so there are a lot of variables here. I mean, you certainly got material variables, but you've got electricity and chemistry all working in ways that I don't understand. But what has come to light is anodization, in addition to changing porosity, also changes chemistry. And that really matters, because as it turns out, it's not just surface roughness, but it's surface chemistry that matters. But with anodization, you can change thickness all you want, you can change chemistry all you want, you'll find you can change color. But ultimately what matters is, and I don't know enough about the chemistry of this, and I'm not going to pretend to, so I read the article. You can have hydroxy groups exposed on the surface that creates a hydrophilic surface and adhesion points for body's healing proteins, which the other technologies can't do as well. And so toluene anodization creates more surface groups, hydroxy groups. And so versus the competitors, the green shows you cells adhering to the implant surface, which is a good thing. The more cells that adhere, the more opportunity there is for immediate early integration, immediate bone formation as rapidly as possible, and faster early healing. Okay. Now, look, hydroxy groups are important to dentists. They've been important for a very long time. Without hydroxy groups, half of you wouldn't be here because obviously the most important hydroxy group is this hydroxy group. Right? Am I right? Ethanol has got an exposed hydroxy group with a few carbons. And so we've always been big fans of hydroxy groups, and certainly in Kentucky, big fans of one hydroxy group on a small, very small carbon chain. And so this is not new stuff for us, but what it allows us, being a Nobel again, to do is, if you can change the chemistry and maintain the integration, then you can decrease the roughness. If you can decrease the roughness, then you can decrease the risk of bacterial colonization and growth and implant failure. So now the implants that we are putting in, and we're in the process of changing, but the ones that we're ordering are going to look like this. Now, before you guys get scared, from a restorative standpoint, nothing changes for you.
Perfect.
At least for this moment, until I get a little farther. Okay.
Great.
At least nothing changes for you. It's still that internal connection, conical fit, nothing changes. The implant's different. And where the implant is different is, I'll start at the bottom where you want bone to attach. It's very rough, very porous. You get great bone attachment. As you migrate up the implant, there's a gradual change in the microgeometry. The macrogeometry of the Noble Active implant is not going to change. Okay. The microgeometry changes so that there's less porosity, but more chemically active, right? Till you get to the collar of the implant now, where you have much less roughness, but much more biologic activity. And as an added benefit of this electrochemical process, you can affect a color change. And so if you've had abutments that show in patient's mouth and send it to the lab to have the abutment anodized, right? Because gold doesn't show nearly as bad as a dark gray through thin soft tissue. These implants are already pre-anodized for you. So they're gold at the platform. So not as good as pink, but they're gold, which doesn't show through tissue nearly as much if the tissue is thin. So the implant is anodized for you at the top to a gold color, which has got much lower roughness, but chemically better activity. And as you go deeper in the bone, you've got greater porosity, better bone bonding. I tried to get them to do this for years with hydroxyapatite, and they wouldn't listen to me because they never listened to me, but I'm almost always right. And the HA coating that Stereos, and then later when Nobel bought Stereos had, those implants did not fail. They did not fail. Unfortunately, Calcitech had HA coating that fell off, and those failed and it ruined the brand, if you would. Not Nobel's brand, but the HA coating on any implants, right?
Wow, wow.
Yeah. Calcitech's just flaked off and the implants fell out. Stereos's was fabulous. Nobel said HA coating didn't work and wouldn't do it. Then they bought Stereos and the replace implant. And shortly after they bought the replace implant, it was 66% of their business, and 66% of the implants that Nobel sold are HA coated. I remember that because they were both 66.
Right.
And but not anymore. So the implant's different, but nothing changes for you. Okay.
Good.
Still the same prosthetic connection. And so we've just got different zones now that take advantage of electrochemical things that I don't understand, and I don't want to pretend to understand, but I can read the peer-reviewed literature and try to understand. Did you raise your hand, John? that a question? Okay, because if you'd been in an auction, you'd have bought a cow just then, just so you know. And so the implant's changed, but it's not gonna change for you guys right now.
Scan bodies and impression copies the same.
Everything's exactly the same if you get the implant in your hands like this. It's all exactly the same. Nothing changes. Nothing changes at all. If I didn't tell you we were putting a different implant in, you would not know. Until the next part. Why is it that every implant company feels they've got to show a slide like this?
That's supposed to be blood.
Yeah, that's blood going up,
Okay.
following it, which I think I could probably do on my arm if I stuck it in. But it's also a protective layer on this implant, which will not get washed away until body fluids hit in, which then exposes the hydroxy groups, which then allows proteins to bond. So I'm not going to dwell on that. So again, you got a collar that promotes early integration, maintains bone. Again, I'm not talking about any of the macro geometric aspects of it, right? The reverse taper,
Right.
the platform switch, the conical connection, the aggressive threads for immediate load, the double threads. I'm not talking about any of that. The smaller the thread design at the platform all maintain bone. I'm talking about micro geometry and chemistry. And then the apex, more bone related with less focus. So anyway, the implants are the same. You got the gold color, but the implants are the same as far as yours. So now, your least favorite thing. So we good on that?
Yep.
Make sense?
Yeah.
Excellent, excellent. I tried to teach my wife how to tag calves, and she declined to do that. But Jackie, I think since your grandfather had a dairy,
Yeah, there you go.
I think we're gonna put you.
They'd chew me up.
Well, you can hide behind the ATV like I was. I didn't take a selfie, you notice. So there are two more issues that are problematic. Remember I said earlier that we don't judge implant success based upon soft tissue, because I don't care how pretty your crown is. If there's not a soft tissue frame around it,
It's not gonna look good.
it ain't pretty. Where you're gonna pack food. And sometimes it's inevitable. I mean, it is what it is. Patients have, I had a patient today, as a matter of fact, said, I love it. I've had it for years. It does tend to pack a little food. And I said, well, some cases we do lose a little bone despite our best effort. She said, well, my tooth before it packed food too. That could work a damn miracle. And so there are some other things we can do better. Somebody asked me one time why we bought Nobel implants, and the answer was, and he said, because they're more expensive, you can buy cheaper implants. And I said, well, I said, if I only buy cheap implants who copy Nobel, then who's going to do the research to make everything better for all of us, right?
Mhm.
And so we still put in the best implants who do all the research, and everybody else copies it in 10 years. If you wait another few months, you'll get to buy the, not that you guys are going to, but you can buy Straumann's copy of the Noble Active implant, because their first edition has failed miserably. And so they had to redo it. So they're copying the active. They kind of copied it the first time, but they didn't copy it just right. And then so now they're copying it exactly. So two issues. One is it's challenging for the restorative dentist to work on the implant level. It's challenging for it's a pain in the ass for me to work at the implant level, okay? Not as bad today with the conical connection and the platform switch, because, on these old flat implants, if you got a little bone or a little soft tissue, you never got the abutment down. It was always a pain, and so it's very difficult. But it's tough to work at an implant level, right? And secondly, soft tissue doesn't like being abused. And abuse to soft tissue is when I take out a tooth and place an implant, then I place a healing abutment. The soft tissue will adhere to that healing abutment. Then the patient comes in here and we remove the healing abutment and that tears that soft tissue adhesion, and that causes inflammation, and then the soft tissue will recede a little bit, and the bone will recede a little bit. We'll torque test the implant before we send it to you guys, and then we'll put the healing abutment back on, and then we'll come to some of you, and you'll make an impression. So you'll take the healing abutment off, put an impression coping in or a scan body in, and do that, and then you will replace the healing abutment, and hopefully everything will fit the next time and you'll be done, but you've manipulated it 4 or 5 times, and we don't want to do that. So we want to maintain soft tissue. So how do we improve our maintenance of soft tissue and simultaneously make your life easy working on your implant patients? Because you don't want to get down in the blood and the muck. That's what you pay me to do, or your patients pay me to do, is get in the blood and the muck. And just to reiterate the process, the more you take the abutment off, the more you disrupt the junctional epithelium, the more you cause inflammation, the more soft tissue and bone loss results in your patient's mouth. The holy grail for implant dentistry for 25 years, in my mind, has been to put your definitive in and don't take it out. Don't take it out. Your definitive, meaning your restoration on top of the implant. Now, putting the final restoration is impossible, but putting an abutment in, and I went to a lot of effort at one time to get an abutment in simultaneously. The surgery that did not have to come out. I spent a lot of time, and it was just impossible with the technology that was available, or I wasn't very smart. Now, there's a whole body of research, preserving more bone, micro movement of abutments causes bone loss, abutment disconnections, bone loss even in platform switched implants. And this is old stuff. What? That's from 95. This isn't last year or 2 years ago or 3 years ago. This is not new news. There just wasn't a technology to deal with it. And so what's the solution? Well, instead of putting a bone level implant in, I can put a tissue level implant in. If I put a tissue level implant in, you guys are screwed for angulation correction, right? You're screwed if any recession occurs. If I place the implant 3 millimeters deep and patient gets a millimeter recession, you still got 2 to work with, right?
Right.
If I put a tissue level implant in, the implant is tissue level, you got silver showing through there as it is. Anybody ever had a patient on a second molar come in and say, I could see a little metal on the outside? I can't tell you how many times that's happened. You know, stupid dentist just screwed it up, is what I usually say. And so, no, they don't like metal showing, and we obviously prefer to not have metal showing. And just for what it's worth, did any of you all, probably you, Charlie, or maybe you, Jackie, get to restore the Noble Active 1.5 implant, the 1-piece implant, yeah. The Noble Active? Did you get to do one of those? Is that patient dead?
It's been so long, I don't know.
Yeah, I hope the person's not dead, but
right. Yeah, maybe we got
what I'm saying.
Yeah, exactly.
Before Noble Active bone level implant was available, Nisnik's internal hex patent had not expired. And so to work around that, Nobel sent out what they called the external Noble Active, which was a 1.5-piece implant. And so it looked just like the Noble Active, except there was basically a post sticking up, which, as I told them in my written report, was the worst of both worlds. And even if they gave me the implant, I wouldn't use it. That's the words I sent to them, much to their consternation. But as usual, I was correct. Because have you ever seen one, Craig? Okay. Because they immediately pulled it off the market. Because you also, by the way, the abutment was a friction fit. So when the patient came to you guys, you had to use a mallet to tap it on in the patient's head. Anybody want to do that? No. Exactly. Pointing. Now, scientifically, it was actually fabulous. But practically, no good. And so we want to maintain tissue. The best way to do that is not to put a healing abutment here and take it on and off. The best way to do that is to place a tissue level implant and leave it there, right? But then if you have a problem with the implant or you need angle correction, you're screwed. And none of us wants to be screwed, at least in our office. And so we need restorative flexibility and I need peace of mind. So that led to the development of the On-One. Now I've talked about On-One with you a few years ago. Unfortunately, On-One got held up in regulatory approval in this country. It's been around for several years. And so for those of you who are putting your abutments in now, or seeing the abutments we put in, you know that there's generally a titanium base that goes in when the abutment goes in, right? A little tie base. Yep. So let's make it simple. What if we put the tie base in at time of surgery and it just stays in forever? Woo! Yeah, Jack, you like that idea, right? Keeps you away from the implant. It works well. And so we put the tie base in at the time of surgery. And now the tissue can adhere to the tie base. I'm calling it a tie base, but it's an On-One concept, but it's still a piece of titanium. And it stays in, and we don't disrupt that tissue so much. Okay, make sense?
Yeah.
Okay, and so now we can place an implant, place the tie base, that's the restorative interface. And so here is a traditional bone level implant, no belt, and a tie base On-One concept side by side. Which level do you guys prefer to work at? Is there a question? Right, yeah. Now, and not to focus on the negative, but I focus on the negative with my patients every day. If something goes wrong, you get a little recession, or you got to do something different. We just unscrew the tie thing and throw it away, right? It's not there forever. You've got flex. Well, hopefully it's there forever.
Right.
But it doesn't have to be there forever.
Okay.
So if we need to do something different, that can become a throwaway, all right? So you've got built-in flexibility here. So it's not that big of a deal, but you've got a lot of potential because now this is gonna be tall. It's not gonna stick up in the mouth, right? Not gonna stick up in the mouth, but it's gonna be tall enough that that continuous connection, disconnection doesn't impact those adherent soft tissues. Make sense?
Mm-hmm.
Yep. Okay. Got healing abutments, just like our healing caps. There's already an abutment on there, so technically it's not a healing abutment, it's a healing cap. And Charlie, you'll like this. It's actually got a healing cap, which is a scannable abutment, a scan body, all in one. So it comes into your place, you wave a magic wand over it, and you don't have to do anything. Take anything off, and you just go boom, 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 and you're done.
Take a shake.
Yep. I could have sworn you said take a shit.
No, shake.
Okay, I'm sorry about that. It's been one of those days. One of those days. After the cow almost killed me, that was it.
That's right.
Yeah. So you can just scan. Don't have to do anything. Just wave that magic wand and send it to the lab.
Yeah, that's nice.
Yeah. So you don't. So basically, what will happen? I'll show you it a little better. Is it makes your restorative easier.
Yeah.
Because now you're working not as deep.
Right.
You can preserve the soft tissue around the implant because you're not taking this abutment on and off. There are different heights of this, a couple of different heights. And you know, obviously, again, if you got to take it off, then you kind of defeat the purpose. But you got to take it off for other reasons. You can take it off. You're not stuck like you would with a traditional tissue level implant, right? And you have options, screw, retain, cemented, whatever you want to do. I'm not going to dwell on the details of it. I just want you to be aware of it because I don't have enough time to go over the details. Matter of fact, I broke my cardinal rule on this presentation. I always have clinical cases, but I didn't have time for clinical cases to get you guys out of here. So, implant goes in, the On-One base goes on, okay? Stays on forever. Hopefully, but not necessarily. So you're not locked in. Healing abutment can go on. You can take a standard impression, make a screw retain crown, a cemented crown. Alternatively, the On-One base goes in, the scannable peak abutment goes in, and you just scan, boom, 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 you're done. 8 minutes, the patient's out your door, right?
Yeah.
Give or take. About 8 minutes, right?
Yeah.
About 8 minutes. So the concept that Nobel's working on is what they like to call muco-integration, which I really hate the term, but it's their term. It's kind of like all on four. I hate all on four because that's a stupid term. Because patients don't know what all on four means.
Right.
You know, they think it's a gear shift in a truck or something. And so muco-integration, we talked about this new chemistry, if you will, that allows the bone to attach to the implant without increasing surface roughness, but we really don't want to roughen up an abutment like this on-one concept, for example, because again, we need cleansability, right?
Mhm.
We still don't want bacteria adhering. Well, the beauty is, along with the new implant surface, there's a new treatment now for these abutments. And that treatment for these abutments is not porous, so bacteria don't attach, but it's got an enhanced surface chemistry, and it's gold, which again we like because through soft tissue, gold doesn't show nearly as much, it's not nearly objectionable for your patients. So it's gold, but it's designed to enhance that soft tissue adhesion. When we can put this in day of surgery, well, we've got a bleeding surface post-extraction, right? And so that's a win. And so I'm not going to dwell on this, but if you look at a machine versus a new zeal, whatever you would like, however you would like to pronounce, zeal. How you say it, Craig?
Zeal.
Zeal.
Zeal with a Z.
Zeal. With zeal, like Xerxes. Yes. Like Xavier.
The X is like an H, it's healed.
Xavier.
Yeah.
I think in Europe it's seal.
Seal, yeah, it's Europe, it's seal.
That's the guy with
Yeah.
scleroderma. Yeah, right, scleroderma. And so if you look at epithelial cells, they grow much faster on this new gold hued titanium, and I'm going to call it a tie base, but it's the on-one. And you can see the benefit of that. There's actually less bacterial adhesion to the new one than there was to the old one. You got more stable bone, because remember what I showed you before, the more you take these things on and off, the more you lose bone. You got a 2-year follow-up, and you have less recession. And what happens when what tissue do you lose when you have recession? You lose keratinized tissue. You have keratinized tissue, but you also lose bone because the bone follows the tissue follows the bone. The reason you lose the tissue is because you're losing bone. And so you're actually enhancing and plugging and maintaining your site. So now you've got an abutment that we can put in. Again, this is taking the on-one. The on-one came out before this technology was released. And now the on-one is being being improved with this technology. So you save keratinized tissue, you save bone, you save headaches for you guys. And so now we've got implants and abutments that minimize microbial contamination. They maximize surface energy for adhesion, whether it's soft tissue or hard tissue, and hard tissue or soft tissue. Hard tissue is just soft tissue that is calcified. You've got a golden hue to improve appearance in situations where you've got a problem. You've got the flexibility to leave this in after day of surgery and take advantage of those benefits. But if something untoward happens, you can remove it and fall back on your traditional technique. And so you're not locked in. So you've got all the advantages of a tissue level implant without the disadvantages of a tissue level implant. And so now you've got multi-unit abutments, you've got the on-one, you've got several options. Not all options are available, to be honest with you. They're still working on that. This is not my case, but a case from somebody in Europe. But the techniques are the same. Taking impressions, you're doing all the same stuff. I didn't dwell on techniques because I didn't have time because it was too much information. So the new implant you're getting is not going to change your life in any way, shape, or form, except hopefully decrease what is our relatively low incidence of implant problems due to microbial contamination, number one. Number two, the on-one concept, which is very early in the adoption stages, will help maintain soft tissue as a concept in and of itself, and then with the new coating on the new treatment, coating's not the right word, the new treatment of the abutment will enhance tissue maintenance. Now, we've still got to work on a few things on that in the anterior, and there's some other issues. So we're still working on that, but there's a possibility we will migrate to that in the future, but not at this moment. Dr. Vieira might, but he's more aggressive than me. He's braver than I am. I'm old. Hard to change my ways. You got to prove to me I need to change them before I'm willing to change them. And so you're going to see changes in the implant, but it's not going to impact you. And we're already putting these implants in, by the way. Again, it doesn't impact you, doesn't matter. The On-One, beginning to put some of those in selected cases, and you may see those, but I'm inclined to tell you ask you if you want them or not before we do those. Okay. So that'd be your choice.
Great.
We're like Burger King, right? Hold the pickle, hold the lettuce, special orders don't upset us. All we ask is that you let us serve it your way.
Wow, that's impressive.
It's a food commercial. Food commercial. 2 all beef patties, special sauce, lettuce, cheese, pickles, onions on a sesame seed bun. I can do this all day.
I could not.
All right, so I'm going to quit there, but anyone have burning questions? Too much science, right?
That was great.
But it's important stuff to know. I don't want you to get surprised by a gold topped implant if you happen to see one. I don't want you to be surprised by an On-One. But you won't be surprised by an On-One because I won't put it in unless I check with you first. Because if for some reason you don't want it, you're the contractor, I'm the subcontractor, it's your patient. You get what you want.
Is there for a time that it's a discipline that she used that? Because from what I'm understanding, it sounds like it's pretty great, most cases.
I think there are probably some anterior cases where it'll be challenging a bit for significant ankle correction. The failure of the surgeon to place the implant deep enough would be a challenge, which hopefully won't happen, right? There will, I hope the technology is going to evolve a bit to make it a little more flexible. Not all the abutments have to shift. It's still early in the game, right? So hopefully if we ask you to put it in, it's the appropriate thing for that case, right? I guess we answer it that way better.
Oh, thank you. That's a decision for me.
I don't want to do that for you, but I think there are situations where we want to use it in situations where we're going to tread more carefully because only so many folks I can blame for problems, and the fewer I cause, the better. But clearly the implant, I believe the implant would be clearly superior. The abutment, I think, is superior in the right indications, but there are some that I'm still not positive about. So we'll do, as always, strive to do what's best for the patient in that particular situation.
We've got a question about the healing cap for the scan body. So you've got a choice whether you put just another type of healing cap, or if you put a healing cap that
You
has
can
the
just
scan.
put a metal round standard healing cap on there like you would see a healing abutment on our regular implants. I mean, it fits on the On-One, of course. It fits on a regular implant. Just a metal healing cap, or we can put the scan body. Which is just simply a peak.
It's a peak healing abutment or healing cap, I guess.
Yes.
Okay.
So,
So this is pretty long though. I mean,
So you're getting in that situation where you have the anodized healing cap, and then when you bring it up, you're actually getting tissue adhesion.
That is what the science says.
So therefore, I'm just throwing this out.
Sure.
Therefore, your perio issues potentially could be masked by having by having the inability to probe the area if the tissue has went up around the abutment.
Well,
Could there not be a perio issue that would occur down below where you're at, maybe I'm not
No, what you're describing is what Bearhog described 70 years ago as a submarginal periodontitis, where if you probe, the soft tissue was distant enough from the periodontal defect that you couldn't probe because the soft tissue had reattached to the tooth, but you had what he called a submarginal periodontitis,
Okay.
right? So that was Bearhog, published in 50, you graduated after I did, but submarginal periodontitis in the 50s or 60s, something like that. And yeah, that was a long time ago. I guess that's theoretically possible. I think it's practically so uncommon. If it did happen, I would expect drainage and other problems.
That's what I mean, there would be other.
I mean, because the drainage has nowhere to go. You know, with the tooth, there are some other alternatives. With an implant, where the implant and the bone are direct opposed to each other, there's nothing, no place for anything to go other than out through the sulcus, unless there's a soft tissue drainage site. So I'm not going to say it can't happen, because I've been doing this stuff too long to say anything cannot happen. But that would surprise me. And even if it were a concern, I think it falls into the category of risk benefit for the entire population. And if it maintains an extra half to millimeter of tissue on 99.5 patients, then can I tolerate a half a patient out of 100? Potentially, maybe I can. I mean, I don't know. I'm just making up numbers, right? But I guess you were going to say, did you?
I was gonna say that, I mean, it's gonna go the path of least resistance, which is gonna be right through whatever.
I mean, even though it is a soft tissue adhesion, I think that's the only way it's going to go is back up through the sulcus, right? And so again, I'm not going to say it cannot happen. Matter of fact, I guess I would say that if I can put those in the day of surgery and you can get a good seal day of surgery, the odds are much greater you're going to prevent that problem.
Okay.
I'm not trying to pretend like I know. I'm speculating with my best guess.
So on the screw retain abutment, is that a stock abutment that comes with this?
Yeah, they still got a couple of issues to work with. That's what, Charlie, I was being nice, and there's no bell people in the room. So I was trying to be nice.
Come here.
Yeah, they don't have it as well worked out as I would like. I like the concept and I like the potential, but technically, in every case, it's not quite.
Okay, so let's go back to this healing cap. There's got healing cap there on the right, the oral scanning one.
Yeah, the scan is,
So what's that thing sticking out? Is that something?
well, that has to stay in. Patients can't chew on that.
That's right.
No, that's just the handle to place it.
Oh, that's a handle of the place, and then it comes, okay. I got you, that was confusing.
Yeah, that's just a handle to put it on.
Okay, I got
Like the handle to put that on and the handle to put that on.
you, I got you.
Yeah, just a handle to put it on. Sterilized peak. So just scan it and go.
Gosh, that's great.
It's cool.
Yeah.
It's cool. Now, if they would actually just make a mill for me, right, Craig? You know where I'm going.
I'm working on it, yeah. I
Um,
feel like I've heard this.
And let me scan the case before surgery. Let me place the implant, then do a quick scan of the implant where it's at and make a custom abutment and stick it in at the moment of surgery. That would fix all this crap much better. And I've been saying that for 6 or 7 years, and Craig will do nothing.
Are they listening to you?
Craig will do nothing. I talk to Craig, and I talk to Craig till I'm blue in the face, and he still does nothing. And so, but he did take me to dinner the other night, so
Well,
he has a pass for a couple more weeks. I
yeah,
guess.
exactly.
Didn't make me pay for part of it like his boss did a couple of years ago. Because his boss had drank so much bourbon, they exceeded their limit.
Oh,
Expensive bourbon.
yeah.
Nobody told you that story. He's not at Nobel anymore, so.
I wonder why.
Yeah, he's actually quite good. He probably should still be at Nobel. So the implant, I think, is a definite go as far as you're concerned, right? I mean, the implants we're ordering now are these implants.
They'll all be that eventually, yeah.
Yeah,
Right.
as we go through inventory, they will all be that. The on one, we will do some and see how much comfort we have with it and see what complications we have with it. And then we will make decisions going forward. And again, at least for me, you won't get an on-one without me calling
Yeah,
and
unless you
asking if you want an
specifically are
on-one.
wanting to.
Or if you, yeah, the other way around, if you say, I want an on-one, I may tell you I don't want to put it on for some reason.
Right, yeah, I was gonna say,
But,
put it on one and every time unless you think it should be.
But we're gonna work through it together and see if we all feel good about it. Because I don't want 1,000 on-ones out there that turn to shit. Craig will really be, Craig won't come to the study club then, I can tell you that.
We leave in town.
Craig will be,
Don't
Craig
call
will be
me.
jumping on the train going through St. Matthews over here. And so, any other questions? Thanks. I think it's cool. You know, the evolution of implant technology has been interesting, and the new digital revolution is just crazy good for all of us. And so we're getting better, and someday we'll be able to do implants and people won't even know anything had ever been done to them. We get a lot now. The most common question I get after surgery is that it?
Yeah.
Is that it?
That's great.
For singles.
Right.
Full arch is more complicated for singles. So,
You say no, then there's the bill.
No.
Is that it? No, there's the bill.
Yeah, so usually I say that's, well, I can't tell you what I normally say. Inappropriate company to tell you what I would normally say. It's like, sound like my wife on her honeymoon. I always, I can do more if you would like, is what I most of It's funny, we take teeth out and I take the tooth out, put the implant in, and we say, okay, we're done. And they say, the tooth is out now? I said, no, the tooth's out, the implant's in, the bone's in. It's all done. It's all done. You're good to go. You're good to go. Other burning questions? Craig, anything that you want? Craig actually has handouts, which are probably similar to the slides I just showed you.
Yeah, they're
right?
very similar.
And he actually has parts and pieces if you want to look at. Do you have the scannable buttons?
Yeah.
So Charlie, you can look at the
Oh, good.
scannable
Yeah.
button with the hand.
Yeah, y'all are welcome to come up and we can pass
And
it around.
you can play with those a little bit if you wish. But obviously, from our standpoint, if there are things that are going well, you don't have to say anything. If there are issues you need to fix, you can just tell us.
Yeah.
Work on fixing them. And Meek is when?
May 7th.
Yeah.
And
That's
so
the-
it's Friday, May 7th.
Friday after Derby. You'll have time to sober up.
That's right.
My guess is it'll probably be here. I don't see,
That's awesome.
if it's somewhere where we can get a bigger venue, we'll be there, but it's
Yeah,
Off and
first
yeah,
come, first served for here. So.
But that'll,
That'll show up in
But
the now.
it'll be a-
Won't be putting that on.
Then
right,
Zoom it.
yeah,
That'll be Zoom too, yes.
But better to be here in person to ask
Better to be
questions.
here in person because, you know, the Zoom is kind of
yeah. 'cause I had somebody from
sometimes
Florida,
hit and miss.
Yeah.
patient
You're not gonna miss anything in person.
Yeah,
Exactly.
kind of our version of
All
that.
right, anything else? Questions, comments?
Oh,
More bourbon, more hydroxy groups? Thank you. More hydroxy groups?
Good job.
I have to do all the complicated stuff.
Is
Science.
bourbon hydrophilic?
It's both, right? It's both.
Right.
It's the alcohol.
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 Alcohol, right, there you go.